we have been doing a lot of work over the last couple of years in Europe, trying to, first of all, prove unequivocally that the Greenlight treatment is as good as TURP. And the second objective was to understand how many patients could be discharged early. If you know the European system, day-case is not possible in every country. Like in Germany, patients have to stay 2 nights at least, the same in Italy. So we had to develop a special parameter which is ready to discharge. Ready to discharge means the patient is without a catheter, able to void with a residual urine less than 100 ml. So the study is a non-inferiority study comparing vaporization of the prostate with the XPS Greenlight laser versus TURP, and the study is called GOLIATH. We published the 6 months and the 1 year data. The 2 years data are on their way. It's a pan-European study, and it's been a big effort for AMS to put together such a big trial. The reason why we had to do this trial is because after a number of years the Greenlight was on the market, we needed to have a state-of-the-art randomized trial to prove a number of concepts that were required by payers to pay back the use of the Greenlight. As you see from the slides, the outcome has been measured at 24 years, and now there's a plan ongoing follow-up monitoring up to 5 years, which hopefully will provide what is needed, which is the long-term outcome. It's a typical trial arranged like a pharma industry trial, so the quality is considered to be good, and the primary objective was proven. The non-inferiority in terms of outcome, both in symptoms, flow rate, residual urine, with a much lower incidence of adverse events in the PVP group. Now, a sub-analysis has been conducted in UK because the UK government has been quite critical about the use of lasers in the management of BPH. Now, this is the subset of the UK patients. They enrolled a good percentage of patients both in the TURP and in the laser group. And this is the number of, considering the number of patients that were discharged, UK has been obviously the best country. Because of the incentive in this country to discharge patients within the first day, UK doctors are much more ready than other urologists in Europe to discharge patients on the first day. And this is obviously, for example, in Germany, none of these patients were ready to discharge on first day, but simply because doctors, urologists are not used to arrange this. So this is the length of hospital stay of the full GOLIATH cohort. And as you can see, there is, on average, 1 day less hospital stay in the whole study group. But please remember that the aim of the study was not trying to discharge patients early. So this happened just because the morbidity of patients treated with the PVP technique were less. And if you look at the UK data, both the TURP patients and the Greenlight patients had an in-stay time lower than the rest of the whole group because, of what I said, there is a clear trend in this country to discharge patients early. And this is time to stable health, which was defined, as I said, by the patient able to void without an indwelling catheter with a post-voiding residual less than 100 ml. So looking at the GOLIATH study, you can see the number of hours is 50 versus 26 in the whole cohort of the GOLIATH study, and is 21 versus 41 for the TURP group in the UK group. So across all Europe, Greenlight patients had a much shorter hospital stay, which on average is about 1 day less. And this is reproducible in all countries. This is time of catheterization is 22 hours for the Greenlight in the whole group versus 47 for TURP, is 26 in UK versus 43.8. So again, all across Europe, Greenlight patients had a shorter catheterization time. Now, how does this translate into health and economics? Because looking at the whole group, the Greenlight is still slightly more expensive than the TURP group. But if you think that in the UK group of patients, 70% of them, more than half of the patients, were ready for discharge the next morning, and that if 32% of Greenlight patients could be discharged within 24 hours, the treatment is going to be economically viable. So most of us have been using the Greenlight laser to treat patients with severe comorbidities, patients on anticoagulants and antiaggregants. But this is probably going to be the way to use the Greenlight laser in the future, which is moving patients from inpatients to day-case. And the health and economic analysis that we published this year out of the GOLIATH study, using UK as the reference country, clearly proved this. And the figures are quite clear. Total cost after 1 year, including cost of complication, new operations, are $2,800 versus $2,300. So it's a good saving. It's a good saving, and on top of this, in UK and hopefully in other countries later on in Europe, the NHS is providing an extra value in early discharge, which in UK is about £300, so not an insignificant amount of money. Now, obviously, the external validity of the GOLIATH study, likewise any other trial, has to be considered. We had no patients in retention. The average prostate size was around 50 grams, so these were not patients with very large prostates. We had no very frail elderly patients. We had no patients on anticoagulation or with bleeding disorders. We had no patients with defibrillator or pacemaker. Day-case may not be for everybody, but we will always have patients who are not candidate for day-case. But out of the GOLIATH group of patients, which is quite representative of the patients that we treat every day, it proved that a good number of patients, 70% in UK, could have been discharged at 1 day. Obviously, there will always be patients in which this is not feasible, but that's another story. At King's, Gordon, as some of you know, is working at King's College, and he has been using the Greenlight laser as a day case for years now. He didn't make big publicity of this, but most of us who went into the Greenlight treatment visited him many years ago, and we were able to verify that his patients were going home the same day, with or without the catheter, depending on a number of different reasons and conditions, but most of his patients are really going home the same day. And this is a game changer. And this is the way that hopefully the whole system in Europe is going to work and is going to change in the future. So how the Greenlight has been used in the real world. There are no doubts that we have no clear data about how big has to be the debulking effect of treatment in order to have a good clinical outcome in our BPH patients. Some people believe that you can just make a hole. There was a very famous Swedish study of mini TURP versus TURP proving that there is no difference whatsoever at 2 years between a mini TURP and a full TURP. But most of us at the same time believe that the larger the debulking effect on the prostate, the longer is going to be the effect. But obviously there is always a price to pay, and the price is in terms of complication. We all have seen these pictures, you know, with the Greenlight you can make quite a decent cavity, quite comparable to the one that we are used to with TURP. And when you look at the patient on ultrasound, the outcome is satisfactory from an anatomical standpoint. Somebody could say that we always show the best pictures we have, but I mean, those of us who have been using the Greenlight for many years now know that this is doable in the vast majority of patients, and papers have proven that even in large prostates, it can be done. Anybody who tried this laser knows that there are two major advantages. One is very little bleeding. You know, the bleeding is almost absent, and obviously there is no risk of TURP syndrome. But complications are there and may happen. This is why we needed to do the GOLIATH study, because we needed to prove once and for all that the complication rate of the Greenlight is indeed less than it is with the TURP. As far as we know from the GOLIATH study, obviously there is no TURP syndrome. Obviously, there is no erectile dysfunction. Data at 1 and 2 years clearly show that there is no difference whatsoever in terms of stress urinary incontinence, and obviously we had no death. The reason why we put these complications in red, because they are rare, but these are the scary ones. None of us wants to have patients with stress urinary incontinence. Nobody wants to have patients with TURP syndrome or erectile dysfunction. And this is what never happened in the GOLIATH study. Obviously, you know, there are other issues in doing surgery on BPH which are more frequent, sometimes less important, although in the current economic environment, you know, the duration of hospital stay, catheter time, or hematuria is obviously less important, although is highly prevalent. So we know that all patients have some degree of dysuria and some degree of hematuria. By the way, the dysuria rate was absolutely identical between the Greenlight and the TURP, but as we said, hospital stay, catheter time, and in the end, the cost of treatment for the NHS proved to be less for the Greenlight patients. Now, the Greenlight is one of the many trials that has been conducted comparing TURP and Greenlight. These are data from the IGLU. The IGLU is a group of urologists who got together trying to combine their case series over the years to investigate what is the efficiency of the Greenlight laser in managing BPH. And this is a comparison of patients with or without anticoagulants and antiaggregants. And as you can see, the outcomes in terms of flow rate, IPSS, and residual urine are quite comparable. This is just to say that, as we alluded before, moving patients into Day-Case is one of the things that proved to be possible with the Greenlight. But the other area in which photovaporization of the prostate proved to be useful is in the management of frail elderly patients with comorbidities, coagulation disorders, or treatment with anticoagulants or antiaggregants. And depending on your referral practice, you may have a limited number or a very large number, as I have, of these patients, and they come to me just because I have the Greenlight. Now, as we said, the group of Gordon Muir Kings has a very large experience. Oh, here you are. The podium is yours.
Grazie, Professor.
By the way, is the tube working?
I think you were, the tube is working, but okay. Southeast trains are not. I think you were doing better than me, though. I'm so sorry, I've been 1 hour and 50 minutes, and the Southeast train from Seven Oaks got shunted back. But I think Professor Tubaro was possibly doing better than I might do, so I'll just very briefly go through the sort of UK real-life practice. I think what Andrea was saying is that our igloo practice is very much high-risk patients, big prostates, lots of retention. And one of the problems with Goliath was that we weren't allowed to include patients who were on active anticoagulation. We weren't allowed to have patients with pacemakers, defibrillators, patients with very large prostates, very elderly patients. And that is the vast majority of what we see at King's College Hospital and manages day cases, as several of you in the audience will know. So the situation is that we don't have any upper age limit for daycare surgery. In fact, we feel that the older patients are, the safer it is for them to be in their own bed, and I think Ian has alluded to that. There's a measurable risk of delirium in the over 75s if you admit them even for one night, and there's also a risk of social workers seeing them the next morning and then keeping them in until they die of C. diff because they haven't had a home assessment. That may sound sardonic, but actually I've had that problem before. We use it for prostate cancer palliation. I'm not saying it's better than TURP for this, but we can send these high-risk patients home the same day, and if you've only got 3 months to live, then daycare surgery is arguably even more important. We do catheter-free bladder neck incisions with the Greenlight. We do ASA3 patients, as long as they're stable ASA3 patients as day cases. And we publish data in all of these subgroups. What we tend to do, from a pragmatic point of view, is that if we've got very frail patients, those who iteratively need cardiac monitoring, or patients who have nobody at home, we'll operate on them in an afternoon list. 5 o'clock in the afternoon, we'll keep them one night, catheter out at 8 o'clock in the morning, home at 10:30, 11 o'clock. So they're still less than 24 hours, but not what we'd look on as a British day case. But 90% of our patients are in and out of hospital within 6 hours during the day. And our readmission rate, even though we do the majority catheter-free, is still less than 1% within 24 hours. It's not zero, but the majority of these patients, even the retentions, are going home without a catheter if we operate on a morning list. And of course, what's very important is this is a team effort. It's not just the surgeon. You must have senior anaesthetists. You must have good nurses. You must have people telling the patients they're going to be safe going home. And that was probably the easiest and quickest talk I've given in the last few years. Thank you.